Last week, I mentioned that I had two things to talk about, two important topics to talk about. And the first one was the fact that we kicked Matt off of the Ultrasound podcast. Now, I think it was mutually beneficial. I think we're all happier, and I wish him well. I'm sure he wishes us well. He's just moving on a different direction with the Wild Health organization that he is a part of, and it's awesome. It's actually really cool. Definitely check it out. Now, part two is what I want to talk about this week. So excited. It's probably been about, it feels like years in the making. What we've done is we've combined the three main online stuff that I'm involved with. So 5-Minute Sono, Ultrasound of the Week, Ultrasound Podcast. We are combining those into one website. Now that new website is called coreultrasound.com. And what I've done is I've taken all of the Ultrasound podcast videos, so that is all the 200 plus videos that they have published, and I put them on the website, very easily searchable. I did the same thing for 5-Minute Sono and the blog 5-Minute Sono, taken all of those and migrated all of them manually onto this new website. I did the same thing for Ultrasound of the Week. So all of the content from 5-Minute Sono, Ultrasound of the Week, and Ultrasound Podcast is now on Core Ultrasound. Now the plan is basically to have one website where you can just go to it and be able to access all of the stuff. And it's all cross-referenced. So let's say that you are watching a 5-Minute Sono video on pericardiocentesis, and you're like, man, I want to learn more about it. You can click the tagged videos that will be available, easily searchable, and everything from Ultrasound of the Week, 5-Minute Sono, and Ultrasound Podcast, everything that talks about tamponade will be easily searchable. So you have it all in one spot. Now, this is still evolving. We're planning on doing a lot of stuff with the website. Now, this is definitely an evolution in progress. We are working on constantly improving this. For now, if you type in 5-Minute Sono, it'll just automatically redirect to my site. If you had a certain link on one of your maybe FOMED resources, your medical student training, you don't have to worry about having to redo everything. If you type in 5-Minute Sono / whatever video, it's going to automatically redirect to the Core Ultrasound website. So it shouldn't be any more work on your end. I just like this new website. It's clean, everything's together, and yeah, I'm excited about it. So what I would love is if you guys see anything that you would improve, anything you don't like, please let me know so that I can adjust it, so that I can fix it. Now, as far as content, I'm planning on publishing a video or a podcast on Mondays. On Wednesdays, we're going to have Ultrasound of the Week posts, and then we'll have Instagram, Twitter, all other blog posts, all other media kind of scattered throughout the week. Now, what I want to talk about next is CastleFest. Now, today is Monday, March the 2nd. This is the last day that you can use the discount code GoodbyeMatt to get 15% off of CastleFest registration. Check it out. The website URL is castlefest2020.com. We got some phenomenal instructors there. And what I want to do this week with what I'm going to be publishing is show you some of the content that we're going to have there. Now, the person that I'm going to be featuring this week is Claire Heslop, an emergency physician out in Toronto, Canada. Phenomenal person. She does a bunch of those ultra marathons. She's a great runner and also a great ultrasound educator. This is the lecture she gave last year at CastleFest, where she talked about the aorta and the kidneys. So check it out and let me know what you think.
If you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
Yeah, we can definitely do that, or we could be better clinicians and use our ultrasound.
This is going to be a nice, easy introduction to something that's easy, basic, and lovely to do in your department. The first part of my talk will be about something that I really found to be very useful in my practice and very easy to integrate and really important and lovely to teach. I hope that all of you get a little bit more experience aorta ultrasound and bring it back to your practice, because if you get anything from this conference, you should be aiming to get the things that will change your practice and help your patients and be something you can take into almost every clinical environment. In fact, ultrasound of the aorta was one of the first applications in terms of how point of care ultrasound changed primary care and changed emergency medicine. abdominal aorta aneurysms are actually relatively common. 10 to 15% of people who have smoked over the age of 65 will have an abdominal aortic aneurysm, and these are asymptomatic. And these are picked up very easily by bedside ultrasound at the level that we all are able to do. So it's a great thing to be able to learn how to do because you can pick it up and you can change lives. The other thing I'm going to talk about is something that's also very common, is ultrasound for renal colic, ultrasound for looking at the kidneys and bladder to identify some of the secondary signs of renal colic. And this can not only change how you identify the problem for your patient, but it'll also change your department because you can make that satisfied patient get out of your department faster. So we'll talk about that too. So I like to use cases when I discuss applications of ultrasound, and the first case I'll bring you is an 85-year-old who's complaining in your department of feeling weak. Now, I'm not yet 85, but I expect when I'm 85, weakness will be pretty much my run-of-the-mill feeling day to day. But your patient is complaining of feeling more weak than usual. Probably not a lot of Canadians in the room, but who's Canadian here? Does anyone recognize this gentleman? That's okay. He died a couple years ago. This is Ed Whitlock. Ed Whitlock is a very famous runner. He set the age group records for the marathon in basically every age group since he took up running again after giving his knees a rest for about 40 years. He ran a sub 3-hour marathon at the age of 74, right? And at the age of 85, he ran a sub 4-hour marathon. So he slowed down a bit. Ed's physiology is very unique. He has a VO2 max in his 80s of someone who's sedentary in college, and the neural activity in his muscles actually didn't decay over time. So he's a bit of a genetic, interesting creature. But let's picture a fit 85-year-old rather than just Ed in your department. Because not all the 85-year-olds look like this. And this is Ed crossing the finish line of the last marathon he did in Toronto. I remember the year that I beat Ed, and I felt really bad about it. Like, he's having a bad day. You okay? Because he always whizzed past everyone. You can see the people on his left and right look a lot more tired than Ed does. So go back to your guy who's complaining of weakness. You've got an ECG, which doesn't help you. Your blood work's not back. But more importantly, the systolic is low. And you've just come back from a course somewhere nice and pretty. And so you put your ultrasound on. And I apologize, my clips will come through as best they can in the sunlight here. And so I'll point out what I can in terms of what we're looking at. Is there? So you put your probe on and you scan down the abdomen, even though your patient's not complaining of belly pain or back pain, but there's a hypotensive older person. And you identify a dilated aorta. And that person gets to the operating room and survives despite having a hole the size of your finger in the ruptured aortic aneurysm. So this is what we're thinking about here. So back to William Osler's age where they didn't have ultrasound to diagnose AAAs, AAAs were a big problem. And if you were to sit down with a piece of paper and you were like, okay, you've been given the task of designing a really horrible disease. You've got like brainstorm what would be the worst horrible disease. Well, you'd want to make it common, but not really that common that everyone's going to have it. So you have to think about it, but you don't know when it's going to appear. And you definitely want to have it present with symptoms that were confusing and useless. Who's got people in your department with back pain? Well, that's a symptom of a ruptured AAA, but that's not actually what they all have. Belly pain, tons of them, but they don't all have ruptured AAA, so it sneaks in among those common indolent presentations. You'd also want to make it show up in people whose physical examination is challenging. The older folks, the hypertensive, overweight folks. And you'd also want it to present atypically almost all of the time. Most patients with ruptured AAAs don't present with the classic triad of hypotension and abdominal pain and a pulsatile midline. Who presents a triage complaining, doctor, I have a pulsatile midline mass? No one, right? So your physical examination, despite the fact that it gets more sensitive, obviously the larger the aneurysm is still fairly useless in terms of identifying AAAs. And you want to identify them before they rupture, because when they rupture, the mortality is like 80, 90%, right? I don't want to catch that disease we just designed too late. So you design this disease, and also when it happens, they're dead, right? So you want to catch it beforehand. And a lot of the time, honestly, when you go and apply this back in your practice, when you scan the aortas, you're going to pick up aneurysms that are not why they're there. The patient with the back pain has an aorta that's 4 or 5 centimeters in diameter. It's not rupturing today, but they didn't know it was there. So you actually identified it. And by bringing to them the information that they have an aortic aneurysm, you can actually tie that back into their primary care, even if that's not why they're dying today or what their problem is, or they're here for actual MSK back pain. If you identify that AAA, you're going to save lives. And we know this from systemic reviews, that identifying the abdominal aortic aneurysm, we can actually do this very accurately. It's much better than the physical exam. So from large systemic reviews, we know that the sensitivity, when there is truly a dilated aorta, is somewhere in the range of 96 to 100%, and the specificity is also very high if that's the present reason for the patients showing up in your department. So this is a good test. It's an easy test. It's a satisfying test. And the number needed to treat to save a life is actually 1 in 100. And that doesn't sound like a very, okay, that's not like 1 in 12, et cetera. You might need to scan 100 people to save a life, but it only takes 2, 3, 4 minutes. Even in a hard patient, you can get it done under 5 minutes. And we really rarely get the chance to save a life in 2 minutes in our jobs, despite what the public thinks we do. Okay, so I'm going to teach you how to scan the aorta. I'm going to teach you tips for making it easy for you, and also the pitfalls that we can fall into when we're looking for this disease. I'm going to try to make it as easy as possible because I want you to be able to integrate this into your practice without stressing out about it, make it really satisfying. So the first thing to do is to remember that we have to start somewhere. And I really emphasize in bedside teaching that the easiest landmark for most things is the xiphoid, because even though the patient's body habitus may change with time or be variable, they all have a xyphosternum, right? So you put your finger right there, and that's where your probe goes. And that's the place to start, because when the aorta enters the belly, it's the deepest it is. Because of lumbar lordosis, as you scan down, the aorta will rise up to you. So that's where you set your depth to. And that's where you start looking for landmarks and beginning to identify structures that you're going to use when you're scanning. So you put the probe right at the xiphoid, and you start scanning downward. And that also is a good spot, because even if there's stomach gas, usually the transverse colon is a bit lower, so you'll start to see structures much easier. How far down do you scan? I've had a lot of people ask me that. Well, you probably, if you hit the genitals, it's like too far, way too far. But also the aorta bifurcates. So if you scan down, you're going to pass through all of its branches into the intestines, its branches into the spleen. You see all those branches, they don't actually matter that much for what we're doing. But the branch point that matters is the splitting into the iliacs, because then you stop. Because it's no longer an abdominal aortic aneurysm, right? It's an iliac aneurysm. And I've picked those up, but they have a different meaning. So you're going to scan all the way down till 1 becomes 2, and then you're good. What are we looking for? Well, we're looking for a disease that presents with over time widening of the abdominal aorta because of the stresses creating remodeling of the elastic, blah, blah, blah. Doesn't matter. We're looking for it when it stretches. But the aorta stretches in 2 ways. It will stretch by just dilating out on the sides. It gets really chubby, and that's because it's overall disease with time. It's like a garden hose stretching out, but not every time. So about 5% of abdominal aortic aneurysms are the saccular variety, which is created by a weakness in the wall that's sort of one area that's particularly weak, which then pouches out. And these are also important to find, even though they're less common, because they're a little bit weaker than the classic fusiform type. These saccular aneurysms here are also repaired at smaller diameters because they're weaker and they tend to rupture at smaller diameters. So we want to find them too. And that changes how we scan. I also teach you how to scan in Transverse because it's easier, so I'll show you that. So the first thing you want to look for is a landmark. Whenever we scan, we're looking for the landmark, because even though in our young, healthy models, the aorta will be fairly obvious to you, it isn't always obvious when you go back into clinical practice. So we do learn on nice, healthy bellies, but we want to make sure that you're okay to scan when the bellies are a little less, smooth. So I'm going to teach you where the landmarks are. The first landmark you're going to look for is the spine, because that's the bottom. There's no vessels behind that, right? So you're going to look for the spine, and then you're going to adjust your depth so the spine is sort of putting everything above it in the middle of the field. And whatever the structure is above the spine is when you're going to start looking for the aorta. Now, if you've got your probe orientation towards the patient's right, which will put it on the screen left, the aorta will be on the right side of the screen. That's how you can tell it from the IVC, because they'll sometimes be different diameters, et cetera. Most patients, 1 in 1,000 million will be flipped around, but we're not going to talk about those today. But when you're looking for the aorta, it'll be that round thing that most importantly sits right above the spine. There are some patients with very prominent branches that will also have other structures above, and you could get confused by these guys up here. So look for spine, look for big round thing on top of spine. Sure, it's interesting to identify the IVC, but the IVC doesn't always have a very prominent appearance, particularly when you're using the kind of pressures that get rid of bowel gas. You may squish the IVC a little bit. So you're just looking for spine and the circular thing on top of it. The nice thing, and I do say this a lot at bedside teaching, is pathology is easier to see than normal. That's what's so fantastic about ultrasound. Same thing with retinal detachments, much easier to see than vitreous detachments. Pathologies of the aorta jump out a lot bigger than a regular aorta. This is really nice for us, isn't it? So it's a really easy thing, and if they look normal and small and hard to see, you're probably not dealing with a giant aortic aneurysm. Okay, so it changes with appearance as you go down the belly. I did talk about that. And you're going to go from singular circle on top of spine to bifurcation. Again, that you're looking for spine with the round thing on top of it. And then you'll look for spine, and when bifurcation happens, sort of the unhappy Cookie Monster appearance. You're going to scan from the top to where it bifurcates, and that's okay to stop at that point. Just a reminder, greater than 3 centimeters is when you start to consider that it's abnormal, but it's 5 or 6 centimeters when we start caring and calling surgeons. So it's better as an FYI for the patient when the aorta is 4 centimeters, but they don't start repairing them until they're big enough that the risk is outweighing the surgery, of course. And that's a conversation for your patient and the surgeon you refer them to later on, or they go back to primary care. Okay, so this is the first thing you might see when you're scanning for the aorta of your patient. Down here, pointer malfunction. Down here is going to be the spine, and above that is going to be the first circle you see, okay? Spine, and then red thing above that. And now I've set the depth and the focus position, which is the green arrow on the right-hand side of the screen, so that I can pick up those structures clearly, and I'm going to start scanning down, ignoring the IVC. Let's see what we see. That's bouncing, right? Start to see some branches. As you come down the belly, it becomes more or less distinct, but you can still keep your eye on that circle. And all you're looking for is if that circle gets greater than 3 centimeters, and I'll show you how to measure it. The point of showing this is just to train your eye towards normal. And that's what you'll be doing at the bedside with our patients. So you're scanning this patient, and this is how you're going to feel when you go back and do this at home. It's not clear. You get a lot of what's called dirty shadowing. Dirty shadowing is an interface with our best friend, bowel gas. Because no matter how firm you press, you can't remove their colon, but you can press it out of the way. So the lesson is, if you get dirty shadowing that passes in the way as you scan down, there's some various maneuvers you can use. Bend the patient's knees to loosen up their belly if it's tighter. Usually it doesn't hurt to press. It usually actually feels okay to press on colon when it's not distended. And as you press, all gas moves eventually. So give a good press. As they breathe, the transverse colon may slide back and forth, and all you need to see is the aorta generally through that area. If you press, the bowel gas goes, just slide down. If bowel gas comes back, just press, it'll slide. There was a resident training in my year who never missed an abdominal aorta scan for normals. He is the most patient person. He trained as a surgeon and worked in Iraq for a number of years before moving to Canada. I think that has something to do with why he's patient, because obviously it's quite a different environment. He's like really chill now. But it taught me a lesson that if he never missed one, then I just need to be more patient. It only takes an extra 30 to 60 seconds, and that's the difference between knowing and not knowing. So if there's gas, you press. The other thing you're going to notice when you're pressing is the Darth Vader sign. Has anyone seen that yet? So that's when you're scanning on these nice, healthy volunteers, less so in older folks. But the intervertebral discs are water-filled in our nice, healthy people, and so as you scan through, you may see a face appear, and that's just your Darth Vader sign. Doesn't mean anything. But that's when you know you're looking at the spine, and the force is strong in that volunteer. All right, so you're going to scan down, and you're going to see different things. I've had a lot of people ask me about, why don't we scan in longitudinal? It's really pretty, right? Look at that, I saw that whole aorta, I didn't have to slide. How lovely is that? I can definitely see the aorta, I can see the diameter all the way down. It's beautiful, everyone's impressed. Here's why. If you scan a cylinder and you don't get the middle of the cylinder, it's too small. And the last thing I want is a false negative, so we just don't. You can if you want to make it beautiful, but if you want to rule out a dilatation of the aorta, particularly a saccular one, you can't call the transverse definitive. And if you got a very good, or the longitudinal, you can't call it definitive. And if you got a good transverse scan all the way down, you're not missing anything. You don't need that longitudinal. If you want to show off or save some pretty clips for your colleagues, by all means. But the last thing you want is to miss something that is then big and scary, and you're going to miss it. So if you were to scan transverse for this one, you may only see the small guy, you may miss the big guy. The other thing I just want to mention is you save a beautiful clip of the dilated aorta above the spine here, show it to your colleagues, and you're like, I should have decreased the depth. Because the focus point is indicated on many of the machines as a green arrow, if there is one, and you can adjust that, but also just make it bigger. There was a meme that I couldn't find for this talk that's like, every time you don't drop the depth, God kills a kitten. But your QA colleagues at your hospital really want you to decrease the depth. Make it big, make it beautiful. Okay, so adjust the depth as you go down if necessary, because then if you find pathology, it'll look a lot more pretty. And if you do find pathology, it's totally okay to look at it in longitudinal. This is a sort of dilated aorta. You can see the interluminal thrombus, and there's sluggish blood going through here, hard to see in the daylight. And if you were to measure the abdominal aortic aneurysm, you can measure it in longitudinal, but the accuracy is better in transverse. So how do we measure? Is it top to bottom? Is it side to side? Doesn't matter, just measure the widest. That's it. It's super simple. Measure the outside wall to the outside wall at the widest diameter. If it's not top to bottom and it's side to side, it's the biggest, most impressive number. And we're all like that, right? We like the biggest, most impressive thing. That's why we're in emergency medicine. But if you want the biggest, most impressive number, because that's what correlates with the risk of this patient having a problem, because 5 centimeters and 7 centimeters are very different. Let's say you're scanning, and you're like getting new at this, and you go back to your department, and you're looking at this. It's not a big aorta. It's kind of a little hard to see. It's not big, right? I know the lighting's a little challenging, but does anyone see anything interesting going on here? Sorry? There's a something in there, right? There's a little lumen. So this is here's the interesting thing about what I just taught you about AAAs. AAAs are like 1/3 as common as another pathology, and that's their dissections. So the reason I put this in the talk is that I have picked up more dissections thanks to scanning for AAAs. And I really want to pick up dissections because we know those present even more atypically, okay? And they're thoracic, et cetera. But if they're in the abdominal aorta, you will see them. And the first thing you will see is something looks weird. So just remember that if something looks weird, scan a little more. Because there are artifacts that can look like little lumens inside the aorta. But if you keep scanning down and transverse, et cetera, and that line is still there, it's real. So the first thing you want to look for is dissection. I'll show you a couple of other images. This is a fellow who fell off his bicycle. We have a lot of fit, healthy people. He's like 80, falls off his bicycle. Sir, why'd you fall off your bicycle? Because it was springtime. It's not really a surprise. He's like, well, my legs were weak. Well, that's a different thing entirely. So I was asked by a colleague to do a quick FAST scan. The FAST was negative. I happened to look at his aorta. I saw a funny thing, so I put the probe on his heart and noticed a very large dissection flap. So sometimes the abdominal aorta scan will bring you more information than you expect, and keep looking for those dissections when you do that. And he had dissected off the spinal arteries, which caused the weak legs, which caused him to fall off his bicycle. And it goes from there. So at least he was bicycling up until this happened. So you'll find lots of interesting things when you scan for AAAs besides AAA. So just keep your eyes open for that. So sometimes it'll just look like, again, there's spine here. You see this circle of the aorta. And the branch points can look a little bit like lines in the lumen. So just start training your eyes. But if it continues past the branch points, then you're looking at a dissection. Okay, but we're really just looking for this. Whoa. Bathtubs are just reverse boats. Why do I have Einstein up here? Yeah, he died of a AAA. What was more interesting about his AAA is that he had belly pain on and off through his whole life. And in 1948, Nissen, of the funduplication guy, took him to the operating room for exploratory abdominal surgery, like, Einstein, why you got this problem? Goes inside, he finds an abdominal aortic aneurysm that is not ruptured, maybe not even the cause of his belly pain. But what did Nissen do about it then? Because in 1948, you didn't have a lot of options. Anyone know what they did? Yeah, more cigarettes. Probably. He wrapped the aorta in cellophane. The cellophane was made of cellulose back then, and it creates a foreign body reaction which scars down the tissue and holds it down. And that lasted for 7 years, till 1955 when Einstein's aorta finally ruptured. And he's like, I'm good to go at this point. So it's pretty cool, right? And so some pretty famous people have been affected by this. So scan all the way down till it bifurcates. Wait. Bowel gas goes away eventually, in one way or another. Measure outside wall to outside wall. It doesn't matter which direction. Scan everyone. Now, there's actually a recent study that suggests that if they have no AAA on a previous screening test and they're over 65, they're probably not going to develop one. But I often don't know my patients that well. I don't necessarily know who's poked them before. It doesn't take that much time. If I think they have renal colic, I'll still look at their abdominal aorta. I think that's good standard of care. Obviously, greater than 3 centimeters is abnormal, but we care more about the ones that are bigger because those are the ones that go for repair. And then also look for the dissection flap because that's more common and that's really bad. Okay, and it's the first thing you're going to notice is the dissection flap is just a weird looking aorta. It don't look normal. Who is this person up here? Yeah, why is she on the screen? She died of thoracic aortic dissection after the repair. She didn't survive the recovery from the surgery. So look for the dissection flap. She's also hilarious. Okay. Any questions before we change gears? Because I think I have almost enough time built in to. Good.
What about the inside approach for people with
big bellies?
Yeah.
Again, the same reason that we don't, exactly. You may not attach it appropriately. And I've never found it's better. I do think that sometimes you can sneak a view of the IVC qualitatively in general from the side, but if you're coming from the side, the IVC is the first structure. And you're more likely to encounter interference gas from the other side with the stomach. So I just wait for the bowel gas. And it's true, there's gonna be those patients who have literally too much gas, or if they're free air in the belly, I really can't see the aorta. So those patients are going to the scanner anyway. But if I'm screening them, because I'll just wait. Yeah. Okay, this guy. He's less popular than he was when I made these slides initially. This is our Prime Minister. Well, we do what we can. But he's going to be your quintessential imaginary 46-year-old who comes in with flank pain. He has a history of this before. There's blood in his urine. His vital signs are normal. He was riding his unicycle this morning. So you think he's probably got some renal colic. No donut, okay? No scan for these people. Why do we not want to CT the young, healthy person with blood in their urine with renal colic? There's a lot of reasons. Cancer's bad. If they're under 40 and you get a non-screening sort of CT with all the radiation that comes with it, that's like exposing them to the same amount of radiation, it turns out, as an atomic bomb survivor, and I don't know which atomic bomb they're referring to in that study, but I actually am more interested in the cascade radiation from the incidentalloma that you picked up than they need a screening CT for 3 months later, and you have to go explain why and not scare them. That takes a lot of time too. So cascade radiation and repeat radiation, because these things reoccur. Expectations also suck. A lot of what I do in my department, I don't know about you guys, is manage expectations. I don't think you're getting the MRI today, sir. You don't need antibiotics for your cough. And you, sir, do not need a CT scan for your renal colic. And the more that your colleagues CT, the more the expectations will mount. And we know that these cumulative radiation, the cumulative expectations will clog up your department unnecessarily. So for certain people, yes, if they're really sick or there's something else going on, for sure. But for the straight up renal colic, that first CT is not necessary. Stones reoccur as well, up to 10 episodes per lifetime. More than 50% of people with a stone will get another one. 75% during the next 20 years will have another stone. So if you're going to CT them every time, that's going to lead to a lot of radiation and time in your department, and a lot of healthcare utilization. Depending on where you work, that matters a lot. Oh, they all pass too. Depending on where they are and their size, which is something you can find out later when they don't pass, stones go away. Right? And the complex cases that are not passing will present themselves. And from what I understand about physics, the radiation doesn't do anything to help the stone pass. Okay? And we don't even think the IV fluid does anything too. And there's evidence that Flomax doesn't do anything. So what are we really doing with these patients? Right? We're just making sure they're okay until they come back when something doesn't go well. Right? The other thing is the hydronephrosis. Right? Oh, well, the kidney's going to be swollen. It turns out that if you leave hydro alone for up to 2 weeks, it doesn't matter. Right? Like, doesn't do any damage to the kidney. Kidneys are actually not as accommodating as the liver, thank goodness, in Kentucky, but the kidneys are fairly accommodating. So they can tolerate that extra stretch, and that's okay. It's not a big deal. And we can pick up the hydro anyway, okay? And also waiting is okay. So there's really good evidence of that. So this is, I just throw this up because in 2014, ASET was like, you probably shouldn't CT scan the young, healthy people. But I looked into the literature behind this recommendation, and it was studies from 2003 and 2004 that were not based on bedside ultrasound. So even before you guys all got your ninja skills, they were saying don't CT these patients. And we can expand it to an older age group now that we have these ninja skills. This is an RCT of 2,700 people that looked at assignments to POCUS, radiology, ultrasound, and CT, and found that if you irradiate your patients, they don't do better in terms of pain scores and other secondary outcomes, readmissions, returns to the ED, satisfaction, serious events, picking up things. Big study, good study, some journal out of somewhere in the northeastern United States thought it was good, right? If that's good enough for them, I'm okay with that. And there's also a great JAMA article I didn't show in my presentation that just showed just POCUS these people. And if you're worried, if they have a fever, if they're complicated, if they're sick, that's a different question. But we're talking about most renal colic patients. How do we do this? The good news is this scaffolds very nicely on other skills you're going to have, like the FAST exam, because you already looked at the kidney and you swept the kidney when you did a FAST exam, I hope. So it's kind of the same idea when you did the pelvic ultrasound for free fluid in the pelvis. So you're going to scaffold it on your other techniques. When we did the pelvis ultrasound, in terms of looking for free fluid in the pelvis, we saw the bladder. So this is a hand-eye thing you already know, and I'll just kind of hammer home some of the pearls. When you look at the kidney, you're going to sweep through the kidney looking for the secondary sign of renal colic, and that's hydronephrosis. So when you're sweeping through for hydro, you're going to sweep the kidney, looking at the kidney instead of the interface between the kidney and the liver. You look at the collecting system and the renal cortex, and looking at how hydronephrosis has pushed them apart. I'll show you what that looks like. If I put a stone right here, and I block the ureter, the renal pelvis will then distend and push into the calyces, and then eventually the cortex will be obliterated. And you'd be surprised how much good renal function you can have with a completely obliterated cortex. Most patients have another kidney. It's good to know when they don't, but when they do, things still keep working, even if it looks really bad. And so we don't care, I don't care as much in terms of, oh, mild to moderate, moderate to severe, where tall grande venti, what are we dealing with hydro? Just how much hydro is there is a little bit, a lot, because all you want to know is that the cause of the patient's right-sided flank pain with blood in their urine? Now I see right-sided hydro. It's just there, no big deal. I don't know that I'm going to learn anything more from a CT scan. How big is the stone, doctor? You just got it today. Okay, let's wait and see. If you have a fever, severe vomiting, if you're not well, you just come back. If it's been a couple weeks and it's not gone, you come back, etc. So there's a good amount of education you can do rather than ordering the CT scan. And if you see lots of hydro, it actually isn't that bad. You don't have to necessarily intervene, and that's what they saw in that RCT, is the degree of hydro didn't predict when they came back or when they did poorly. It just was that their kidney felt like doing it at the time. So when you're sweeping for hydro, you're going to be looking initially, and I'm sorry, this is a bit subtle in the lighting, for some dilatation down here. And when it's bigger, it's more obvious. And again, that goes back to what I said before. Bad stuff is more obvious. Yay. The nice thing also about most of our patients, almost all of them, is that they got another side. This is what I like about MSK ultrasound, lung ultrasound. They have two. And if you're not sure that what you're looking at is hydronephrosis, you can check the other side, because bilateral hydro doesn't really make as much sense with what we're talking about unless the stone is very, very distal. And if you want to see what bilateral mild hydro looks like, I guarantee that in your department will be a medical student who hasn't peed in 20 hours. And they are the perfect patient to scan because their bladder is big and they have bilateral mild hydro. And that's okay. It's not great for them. But it's part of what our job turns out to be. So, or scan yourself after a night shift. So mild hydro is a little harder to see. It's subtle. You could practice for that. Big bad hydro is very easy to see, and it doesn't necessarily a bad thing, but it will help you cinch your diagnosis. Okay? The bladder may not be that distended in our patients because they feel the urge to urinate thanks to having blood in their urine. So you're not going to necessarily see a big bladder. And often if your nurses have put in an IV and started hydrating them, that can help you a lot. That's the only thing I find it very useful. But I do like looking at the bladder for renal colic because I can learn a little bit more about what's going on. Anyone see anything go by in this picture? It's not much. It's probably a bladder. At some point in the clip, something will disappear past, and I'll make it a little bit more obvious here. There's a stone. Now stones in the UVJ will actually give you a couple of artifacts that you can identify, and there's nothing more satisfying for your patient than to say, it's almost gone. It's right there. There it is. Because you can see it right there. And you can measure it. I don't know if it has that much accuracy and value, to be honest, but you can see it, and you can use some of the ultrasound physics to accentuate the appearance of that stone. If you put color Doppler on, you and your patient can go, look, it's twinkling. It twinkles because there's so much rebound and reverberation artifact from the stone's presence that it creates a color Doppler artifact. This is called the twinkle sign. Aren't ultrasound terms really cute? Twinkle sign. The other thing you're going to see maybe are jets. Now this video on the right here is looping rapidly. It doesn't go with a pulse. It's just a short clip. But if you put color Doppler on in transverse low in the bladder where the UVJ is, you may see the jet of fluid entering the bladder. And the presence and frequency of jets, you'll still have some jets sometimes, even with mild hydro, even with severe hydro occasionally if the patient's still making pee past the stone, but they'll be of less size and less frequency than on the unaffected side. I find that helpful when I can't spot the stone as a piece of information. And the other thing is you may see the stone reverberating. And if you even were a little bit technical, you don't have to do this, you could sweep into longitudinal and pick up that dilated ureter with the stone, which is basically coming down here, dilated ureter, more distal towards the feet. There's a nice stone sitting right there with a posterior shadowing artifact. I find jets are useful, the twinkle artifact is useful, but they're not always that obvious, but I add this to the clinical picture. And jets are cool. And then the last thing just to add, this is a really cool case from Ultrasound of the Week from Ben's website. You've got a fever and flank pain in your patients. Patient's elderly or a little confused, not really sure what's going on. The urine is foul. Let's say you're admitting them to medicine. I do like scanning those patients for hydronephrosis because often a patient who can't communicate well with me, either from various medical reasons or language reasons, etc., I'd like to know if they have flank pain from renal colic because their intervention will be different if they're septic than if they don't have renal colic. And sometimes when you sweep, you'll see other things. It's a little bit more subtle, but in addition to hydronephrosis, there's echogenic fluid around the kidney and they actually had infections bilaterally around both kidneys. So you'll sometimes pick up other interesting things in your hydronephrosis scan, but I also like it for this urosepsis patient who is unable to articulate whether they have flank pain, because sometimes you'll pick up a stone that should be intervened on, otherwise they're not going to get better. And that's a different consult for you. So scan all your people with flank pain, even if you're going to CT them, because maybe you'll get around it for that patient, or maybe it just wasn't indicated in the first place. Check out the hydro, because that's what we're looking for. And I don't mind if it's mild, moderate, severe. It's cool to see a jet. It's great to see a stone, especially if you can figure out where it is. And remember that patient was over the age of 55, 60, et cetera. Check them for a AAA, because you can have flank pain and blood in your urine from a ruptured aorta aneurysm. So it's important to find it. This is a cool picture of a stone in the very distal urinary system. And I used to show this because I was like, this is very rare. But I had a colleague come up to me last week and say, I found a penis stone. So because the patient was like, I can't pee and it hurts down here, they were actually able to visualize a stone in the very distal urethra, which is interesting, because then you can tell your patient it's really almost gone. Any questions?
About the jet,
Yeah.
the effort and the time that needs to be put to wait for the jet is quite a lot. What do we really
Yeah.
from the study if we know that it's a dynamic finding and it might basically not apply anything?
I agree with you, yeah. So I think your question was sort of about, like, it does take a little time to see jets. And from the studies about jet velocity and jet frequency, they were looking at for jets for up to 1.5 to 2 minutes at a time, which is a small amount of time, but it feels like a long time. And I think they were looking up to 4 minutes in some studies to look at jet velocity and jet quantity, et cetera. And you're right, I don't find that jets are necessarily going to change management. I am already maybe going to look in the bladder, though, for that stone. And so I will put color on to look for the stone. And if I see a jet, I can say to the patient, look, you've got urine still passing past that. I don't think that the presence of jet rules out renal colic, but I do think that if you see it, it's sort of a reassuring feature. It doesn't change necessarily clinical management, and also particularly if your patient has been vomiting and not taking a lot of oral fluids, the jet frequency will really drop off. There are some studies that suggest it improves our sensitivity of our ultrasound, but I don't think they've been borne out by repetition. So sort of maybe we'll find out later on that it was worth looking at them. I just think it's a good practice to get into the habit of when you're putting color on to look for the stones anyway, because I found more stones by looking for jets. So I think that's where the value is. Any other questions?
On the AAA, if you find an aneurysm and you feel like it's saccular, would you get them evaluated by vascular at any size, or you know what I'm saying? Like, is that 5 centimeter cutoff wide?
So the question was with saccular aneurysms, what are we doing? Are we referring them right away? I think any saccular aneurysm I'm referring, and I'm not even at a center where I have to transport anyone. I'm probably CTing them for the saccular aneurysms because it's a really good thing to know. They do repair them at variable sizes, and I think there's a little less guiding evidence in vascular surgery as to when to repair them, and they may look a lot more into patient factors and patient quality of life and things like that. So I don't think the cutoffs are quite as firm. They're going to determine where the saccular aneurysm is, the wall diameter, et cetera. It's a lot more technical. So I'm referring all of those people. Yeah. And I also think that if I see what looks like a saccular aneurysm on bedside ultrasound, I've seen only a few of them. So I want to probably scan those people anyway, because I'm trying to improve my visualization of something that's really rare and challenging. So yeah, I'm referring most of those patients. Because I'm okay with a saccular aneurysm being rejected by vascular surgery. I'm not okay with having one just pop. Neither is my patient. Yeah, that's a good question. You guys are great.
So as usual, Claire hits it out of the park. A great lecture on kidneys and the aorta. Now, if you want to learn from her directly, if you want to get some hands-on training, go to some cool events in Lexington, check out castlefest2020.com.